Okay, then we proceed with the next presenter, which is Emek Kokatürk.
Good afternoon. I'd like to present effect of omalizumab on back depression scores. As clinicians, we all very well know that psychiatric comorbidities are very often in chronic spontaneous urticaria patients. And these patients always usually exhibit significantly increased emotional distress levels and impairment of their quality of life. And no studies investigated the role of associated psychiatric disorders on treatment responses. So in our study, we aimed to determine if depression was present in CSU patients who received omalizumab treatment, and if depression scores got better with omalizumab treatment, and whether the presence of depression impaired treatment responses or not. We included patients from our UCare center who received at least 3 injections of 4-weekly omalizumab. We recorded the baseline and after 3 injections of omalizumab treatment, the urticaria activity scores, chronic urticaria quality of life questionnaire scores, BACD depression scores, and urticaria control test scores. Change in BACD scores and other measures were compared before and after treatment. Patients with BACD score greater and equal than 17 were defined as having depression, and control disease was defined as urticaria control test greater and equal than 12. Clinically meaningful changes in the scores are defined before as BACD score change greater than 17.5% and chronic urticaria quality of life scores 15 points and UAS-7 scores 9 points. So when we see the demographic characteristics, we had 49 CSU patients, and 20 of these patients had depression at baseline, depending on the BACD scores of the patients. When we compared patients according to having depression or without depression, we see no difference between age, gender, disease duration, angioedema, ASST positivity, and disease severity between patients with depression or without depression at baseline. But when we compared the patient-reported outcomes of these patients, we saw that baseline UCT levels, scores, and UCT at visit 3, and the percentage of patients who came disease-controlled at the 3rd visit were lower, and chronic urticaria quality of life questionnaire levels at baseline and at 3rd visit were higher in patients with depression. So the graphic nicely shows the patient-reported outcome results after 3 months of 3 injections of omalizumab. UAS-7, QOL, and BAC scores decreased, and UCT levels became higher than 12 after omalizumab treatment. And change of patient-reported outcomes after 3 months of injection, we saw that 75% of the patients were controlled after 3 injections of omalizumab, and approximately 70% of the patients had a minimally important change in chronic urticaria quality of life scores, and BACD decrease was achieved in 80% of the patients. And 20 patients were found in depression before treatment, while 6 patients were defined as having depression after 3 injections of omalizumab. So when we compare, we see that if patient had no depression at baseline, then the responder rates are 86.2%, while if the patient had depression at baseline, the response rate was 60, which was lower than the patients without depression. And when we compared the responders and non-responders, we saw that baseline BACD scores were higher in patients in omalizumab non-responders, and third visit Bechdel scores were higher in patients omalizumab non-responders. So Bechdel scores decreased significantly from baseline in 80% of the patients. Only 6 patients scored as having depression after treatment, and of these 6 patients, only 1 was a omalizumab responder, while 5 were non-responders. And we found depression in nearly 41% of our CSU patients, and 20 patients had depression at baseline, while only 6 patients were found to have depression after 3 months of treatment. We didn't find any association between presence of depression and disease activity scores, angioedema, autoreactivity, and disease duration. And in the present study, we found that quality of life impairment was higher and disease control was poorer in CSU patients with depression. Of the 6 patients who were found to have depression after treatment with omalizumab, 5 were omalizumab non-responders. So the limitations of our study is decision of depression using only Bechdel scores might lead to underestimating the mental problem, and detailed history on the presence of stress or life events as a trigger of disease is missing. So as a summary, depression is common in CSU patients receiving omalizumab. Presence of depression is associated with lower quality of life and poorer disease control. Treatment with omalizumab improves disease activity, quality of life, and Bechdel depression scores. Depression seems to occur as a consequence of CSU rather than being a cause of it. Presence of depression might impair treatment responses. So there is a need of comprehensive approach while approaching these patients with chronic spontaneous urticaria. We have to investigate carefully the comorbidities such as thyroid disorders or psychiatric disorders and treat these conditions so that we have a better patient care. Thank you. I invite all of you to next UCare meeting in Istanbul.
Thank you for this very interesting presentation. I would have a question to the Bechdel scores. So you said like a cutoff of 70.5% reduction.
Yes.
Why is that?
It's defined in
It's
the former
defined like this. Okay.
studies. Yes, it's not my invention. It's been reported.
Yeah, nice report, and actually very consistent with other reports around chronic conditions with BEC. Did you look at polypharmacy in these patients?
Yes, no patients were receiving antidepressants, but other drugs. For what do you mean by this?
Polypharmacy, it means that
I know
some
taking
of these,
many drugs.
right?
But what about what's the?
Because there appears to be an association of these patients that have a direct correlation between having to take many medications in association with the Beck questionnaire or depression. And so considering that these patients have chronic severe disease,
Yes.
the question is if you investigated the number of drugs that they were taking,
Actually,
regardless
we
of
did.
urticaria treatment, diabetes, hypertension, other comorbidities that may make high.
No, not the other systemic drugs, but we evaluated the antihistamine, if they are taking antihistamines or not, how many antihistamines or not, but now I don't have the results. I can email you later, but we checked this.
What is the prevalence of depression in the population that you did, general population that you did the study from?
The omalizumab, these are the only omalizumab patients.
No, in the general population.
It changes to the population. There are many studies on it, but it's really changing.
Have from the area that you...
No.
I think the prevalence of depression in general population would be between 10 and 15%.
Correct.
Yeah, one more, please. But I think then we have to continue.
Thank you for the nice presentation. My question is, because we must maybe differentiate between diagnosis of depression and real prevalence of depression and prevalence of depression measured with big D, independent of the cutoff we assumed. The sensitivity, specificity of patient-reported outcomes for depression are not higher than 75%, so they are not perfect. But on the other hand, did you look, I'm not aware of the construct of just of Beck, the depression scale, but did you look into, depression is multidimensional. You have sleep disturbances, you have agitation, changes, appetite loss, sadness. Did you look into specific domains which improved? Also with antidepressive therapy, as in the domains respond differently. Did you observe which domains improved first?
For BECD, we didn't but for the chronic urticaria quality of life questionnaire, we found that angioedema was the only scale which was prominently differed from the other scales. But for this, we didn't, but we will check. Thank you.
Okay, thank you for your thank you for the talk.
And we'll proceed immediately with